Okay, thank you, Patricia. So as she mentioned, my name is Andrea Carpenter. I'm the program coordinator over at JESSA, and I'm also a certified PCIT therapist as well as a within agency trainer. And what that basically means is I'm allowed to train staff that work at our agency to also become PCIT therapists so that we can continue to expand the services and reach more families that way as well. And feel free anytime, jump in with any questions. I'm happy to help as we go. Okay, so today we're going to spend some time just kind of generally going over PCIT, what that is, what that looks like, how it's provided. We'll talk about who would be an appropriate client or referral, what families would be appropriate for PCIT, some information about what we give parents when we're doing PCIT services and how we work with them, just to provide you guys with information of what families would be getting into, what they should be aware of and kind of used to when they come in for services. And then we'll talk about some of the differences of what PCIT looks like when we're in the office and how we've had to adapt it during the whole pandemic crisis, which I think what I would say is we've seen a lot of improvements being able to provide PCIT virtually, but then there's definitely some challenges as well. So we'll go through some of those. Just a little bit of background about PCIT. It was developed back in the 1970s by Dr. Sheila Iberg. She worked with a huge research team, and they gathered information about how to support kids with disruptive behaviors. And since then, it's really expanded both all across the nation as well as across the world. And there is a PCIT International website, and PCIT is provided in several different countries. It is an evidence-based treatment, and it's a manualized treatment. And what that means is every PCIT therapist is following the same manual, the same book, the same session outline, so that it's consistent, it's been well-researched, well-studied, and that families can all expect the same outcome from whatever therapist that they work with. Every therapist should be doing PCIT the same way, which is also beneficial if, for whatever reason, a family needs to switch mid-treatment to another therapist because of insurance or because of moving. They should be able to pick up right where they left off and continue services. And this is just a list of all of the countries currently offering PCIT. As you can see, there's several different countries, and the manual has been translated as well into several different languages to really help support every family in accessing those services. So when Dr. Sheila Iberg put PCIT together, she pulled from a variety of different theoretical backgrounds to really take some of the strategies from all of these different models and pull it together into one treatment approach. So PCIT is heavily focused on attachment theory. There's a lot of play therapy. All of our sessions are focused really on helping the parents play with the child. And then obviously a big component is the behavior modification and really working with kids that have some challenging behaviors or disruptive behaviors and helping provide parents with the skills and strategies to change those behaviors and really work on having a more healthy and positive relationship with their child. So these are just a little bit of information about what all is pulled together for PCIT. And I don't know, Patricia, the handouts that I had sent you, had you been able to send those to the participants, or is that something that I can send out later?
I will post them on the website so people will be able to download it from there.
Perfect. So there's some handouts. I kind of summarized some of this stuff here, but some of the outcomes that we are looking for when we're doing PCIT with a child is really for the skills that we're working on in the home with the parent to be generalized to other settings. So often kids get referred for services with us because they're struggling at home, but also in school, daycare, with other kids. Sometimes kids we've worked with have already been kicked out of multiple daycares or school settings, and so it's working on providing skills that really can be generalized to other settings and working in collaboration with the school teachers, if possible, or daycare providers to really help provide that continuity. We work on building and increasing the security and attachment with a caregiver. Oftentimes parents are feeling really stressed and overwhelmed and kind of at their wits' end when their child has some significant behavioral concerns. And we really want to focus on strengthening that relationship, helping everyone feel more secure. We work on attention span, self-esteem, positive social skills, and that really ranges from whatever the child is needing. So it can be working with them on, you know, being better at taking turns or sharing, transitioning between activities, following directions, communicating their needs, being more flexible. So it's really a well-rounded model that we can help individualize per child and what the needs are that they're coming in with, what the family needs as far as support, and really help address any concerns that they're dealing with as far as their child's behaviors and interactions to help everyone feel more secure. And then some of the things we're looking to decrease as far as children being referred to us is really working on decreasing non-compliance, helping them be more calm, so decreasing their activity levels, behavior concerns, and specifically the negative attention-seeking behaviors. A lot of kids really are just trying to make it work, and they find what they can do to get that attention, and often the negative attention brings a whole lot more attention and a bigger reaction. And so we work with parents on how to address that and how to really help kids look for getting that positive attention, both, again, at school, daycare, home, anyone that they're interacting with. And then some of the outcomes we look for caregivers is to help increase these things. So helping their child listen to what they say, have consistency among caregivers. We really strongly encourage, if it's a two-parent home, or even if it's a parent and maybe a grandparent or someone else that's heavily involved with childcare for the child, that if we can have more people participate in the treatment and really get that consistency between caregivers, that we've seen it has a huge success in and of itself. And so we strongly encourage as many, well, 2 caregivers for sure if possible, and then if we need more caregivers, doing more sessions as well to get everybody on the same page. We work to increase kids following house rules and coming up with what those house rules can look like, and really helping parents feel confident too when they're taking their child out in public, that they have the skills and know what to do to help manage behaviors that could come up. I can't even imagine how many parents I've worked with that are fearful of taking their kid to the grocery store or on the bus or out to a friend's house because of the behaviors that they often deal with. And so we work with parents and how to manage those and what to do in those situations as well. And then just helping the caregiver feel more calm and confident in the skills that they have, and helping them feel good about what they're doing as well. And then focuses for decreasing. So we want to decrease the intensity, the frequency, and the severity of the child's aggressive behaviors. I've seen a wide range of behaviors that come in. Some kids are non-compliant, maybe a little bit more moody or talk back, and I've seen everything from kids that are pretty significantly aggressive. They've been kicked out of school, kicked out of daycare, and are very aggressive to parents, and often that's related to a trauma history that they've had. And really, we want to help decrease those so the parents feel like they're in more control and have support. Another big thing is decreasing parental stress. We have parents sometimes that come in with their own mental health concerns. Some have had a substance use history, and we want to help everybody in the home feel more under control, feel more calm, to reduce any risk of anything related to child abuse, relapse, or significant concerns with the parent's mental health as well. Some other outcomes for caregivers is really about that interaction style. We work to help change the relationship, help them be a more authoritative parenting style so that they feel like not only do they have the loving warmth in the relationship, but also feeling like they have the ability to set limits and have expectations and have children help out in the home. And these skills can be generalized to other siblings. So we may have a family referred for PCIT, and we identify one specific child to focus the treatment and skills with, and as far as the coaching goes. But we work with parents on how they can use these same skills for other children in the home, and it may be some mild adaptations for younger kids or older kids, but how they can use the same language as well. So some of the Some of the core features of PCIT that make it a little bit different than your traditional family therapy approach is we do what's called direct coaching with the parent and the child. So the way a typical session looks is the parent and the child are in one room if we're in the office, or obviously in the home. They're playing together, and the therapist observes either through a two-way mirror in the office or through some computer device, phone device, so that we can see what's happening in the moment, and we have a headset or a bug in the ear that we can talk to the parent live as they're getting support and treatment. So as they're playing with their child, as different challenges come up, the therapist is able to tell the parent what to say, what to do, how to respond, help them calm down, take a deep breath, and really support them in the moment as they're working with their child, rather than more traditional therapy where the therapist may give them some tools and strategies to use. They send the parent home, ask them to practice them over the week, but it doesn't always go as well or as smooth for the parent to be able to implement those skills. So the biggest difference with PCIT is that direct coaching piece that feels a little bit awkward, I would say, for families in the beginning. It's a little bit anxiety producing knowing that the therapist is watching and talking to you and trying to get used to that, but that I would say is the biggest difference overall. And we work on restructuring that parent-child interaction. So we really want parents to feel confident, children to listen, and to have that warmth in the relationship as well, so that they feel like they're under control. It's assessment driven. What that means is we use a number of different tools to help us see how the parents are doing and progressing with the skills, what the child's behaviors look like, are we seeing improvement, what are still the needs of the family that we see. And we use a form called the ECB that is a weekly screening form that we send to parents that they can just fill out a scale of 1 to 7. Is this a concern for your child? How often is it happening? So that we can see each week what behaviors to continue targeting as we work with them. We also check in at every session to see how the homework went, any concerns that are coming up, and really focus with the family on what are the skills that they need to work on that week. And we break it off a little bit at a time so that it doesn't feel overwhelming to parents as they're learning the skills. We work with parents to be sensitive to their child's developmental needs. So a lot of times I work with families that have expectations for their child that may not be necessarily in line with what the child is able to do, or maybe a struggle that the child is still working to master. And so we work with parents to be developmentally appropriate in the rules that they set and the expectations that they set for their child to help everything go a little bit more smoothly. And PCIT is trying to intervene as early as possible. So we work with kids ages 2.5 to 7. We try to catch them as the behaviors are not quite as long-lasting or intense. Once kids get to some of the older ages, it's a little bit harder because they've been used to this pattern and interaction within the home, and we try to intervene early to help provide the family with some tools to address the behaviors before it gets to be more significant or the child gets to be much bigger and stronger. And then we take a really positive approach. It's a non-judgmental. We work with the parents at their level. We help them build the skills, and it's really about helping them be positive with their child. We work to be really positive with the parents so that they feel confident, they feel support, and they feel like as we're in this with them together. It's not about the therapist telling the parent what to do and having this expertise. It's really about these are the skills we're working on and how can we join with your family to help it be successful for you in the home. Typically, the length of treatment for a PCIT case is about 12 to 15 weeks, but that really is dependent on the child's needs, on the parent's needs and abilities, and also their follow-through with homework and session attendance. I've worked with families that have been able to graduate treatment in 10, 12 weeks, and I've also worked with families that have been in treatment for over a year. So really it's dependent on what the family's needs are, how they're doing, and what support that they need. But often it's a much shorter turnaround, and by the time they finish PCIT, they're able to graduate from treatment and don't need ongoing therapy after they graduate successfully. Again, we had talked about the sibling referrals. We tend to identify one child and really focus on treatment with them, unless the parent is really feeling like they need support and coaching for both kids or multiple kids. We can always add more, but we tend to encourage them to start with one and really focus on one and use the skills with the other children as they go. And then as far as comorbid diagnoses, we tend to see kids referred with a variety of diagnoses. Some have ADHD, disruptive behaviors, anxiety, adjustment disorder, depression. A lot of the kids I've worked with have a lengthy trauma history as well. And really we're working with them on helping things be more calm, more organized, help them be in more control. And we may need to look at referring them to other treatment once they successfully complete PCIT. Some of our kids get referred to TSCBT after and are more successful in participating in that treatment because the behavior is under control and they're able to feel more calm as they go. So I have a video clip that I'm going to do my best to show you guys and then hopefully get back to my PowerPoint. Let me see if this will work. But this is just meant to be kind of an example of what some of the families might be dealing with. It's from a movie called Instant Family, but a lot of times families referred to us have a variety of stressors, barriers, extra other things that they're trying to do. And so this is just a clip. Sometimes it helps paint a picture of some of the kids we get referred.
My potato chips.
Oh, we're not having.
Can you hear the
tonight,
sound?
Munchkin, sorry.
I want my chips.
Lita, Lizzie, Pete and I worked really hard on this dinner, and there's lots of yummy food for you to eat.
No!
Hey,
Lena,
vete a tu cuarto. Oye, ¿por qué me estás Lizzie, Lizzie, no, okay? I've got this.
Why are you yelling at me? I'm just trying to help you.
I'm not yelling. I am. Just then I was, but it's, look. Lita, don't do what Lizzie just said. What did you say? Cuatro? Go to your bedroom.
No,
go to
quattro
the
means
bathroom.
quart, like quart of milk, right? She said
Okay.
you're not gonna have
Yeah.
potato chips, but you will drink that milk.
In any case, we have this. It's fine.
Okay, fine.
Okay, let's try some of this meatloaf, okay?
No!
Hey,
I want chips!
not having chips.
Yeah, I don't think she's getting on board with the plan, honey.
I don't want this!
You sure you don't want to just give her some chips?
No, we're not giving her chips. We're just gonna eat.
Lita, stay right there.
Oh, sorry, I'm so sorry.
No, it's okay. Don't cry. Relax. Watch your feet, okay? Don't touch.
So
Be careful,
sorry.
okay?
Hey, you give those to me. Give me.
Calm down. Don't cry. I'll get it. Just stay there, Mom.
These are really, really good potatoes.
Oh my God, you okay?
Lita,
What are you doing?
what? I'm trying to put it out.
Ketchup?
Put it out.
Okay.
Sorry.
Lita?
Whoa. What's that noise? Why is she growling? That wasn't in the classes. I got nothing for that. She's got a knife.
It's just a SpongeBob.
It's still a knife.
Okay. Well, so that movie, I think, just kind of shows some of the stress that families go through. There's a lot going on all at once. They're dealing with a lot of things, and parents often feel really overwhelmed, not sure how to respond, how to do things, and the child also doesn't feel good. And so we work in PCIT to really help everyone get along and feel better. So I'm going to spend some time talking about who would be an appropriate referral for PCIT and some of the things that may be a barrier, a struggle as far as a referral goes. And we'll talk through any questions you guys have as well. So PCIT is for kids 2.5 to 7 years old. The later into the 7 or once they turn 8, the skills really don't apply in quite the same way. The therapist would really need to modify and adapt some of the skills that haven't been researched as much. And part of that's just because of the child's cognitive abilities at that point, the development level, as well as their size overall. And the interactions often look very different once kids hit about 7, 8, 9 years old. So we try to keep them between 2.5 and an early 7. And really, any mental health diagnosis is appropriate for PCIT. We see some kids that have an adjustment disorder and some anxiety or depression, maybe some challenging behaviors or some disruptive behaviors, all the way to oppositional defiant disorder and everything in between. We work with kids on the autism spectrum that have a diagnosis of ADHD and so forth. So really any diagnosis is able to qualify them for PCIT, assuming that there's a behavior or a challenge that's going on that parents want support with and skills to deal with. And then another big thing is we need the child to have a receptive language over 2 years old. So some of the kids, especially on like the autism spectrum, if they have a more severe case of autism, it may be challenging for them to understand what we're asking and saying to them, and it wouldn't be fair to use some of the skills in the same way because they don't understand or comprehend. And so we do look to make sure that a child is able to understand what we're doing and how we're interacting with them. That may be a barrier. As far as the caregiver goes, we do need at least one caregiver to be available for all sessions. Like I mentioned, the parents involved with all of it, they are the ones playing with the child, with the therapist and the coach providing support and feedback, but the caregivers in all of the sessions, PCIT is not an individual therapy with the child, and we would never meet individually with the child. We strongly encourage two caregivers if possible. And I've worked with a variety of combinations. I've worked with a parent and a nanny, a parent and a grandparent, an aunt, uncle. So if there are multiple family members that are caregivers for the child, we strongly encourage that. And this doesn't even have to be biological parents. I've worked with foster parents. I've worked with adoptive parents. I've had some cases where I have a foster parent and a biological parent if there's child welfare involved. So we really can be flexible based off what the needs of the family is and who should be involved with that, and can be flexible in how we go about doing that. We do look for kind of a general IQ for the caregiver to be above 75. And really, we don't test them, we're not assessing that, but we want to make sure that the parents are able to understand skills and be able to implement the skills with the child. And it is very skill focused, and so we want to make sure that they at least understand and are able to implement those skills and can do that successfully themselves. And then one of the big things that can be a barrier sometimes for families seeking out PCIT services is we do need the therapist to be fluent in the family's native language. PCIT is a very fast-paced intervention in that the child, parent, and therapist or somebody's almost always talking, and it doesn't leave time or the ability to use a translation service or an interpreter for that. So that is one of the biggest barriers sometimes we run into with PCIT, is making sure that the therapist can also speak the language that the parent speaks. We have had some cases where English may be the parent's second language, but if they're able to understand it enough and feel confident in their abilities to understand the language and use the skills, we've worked with that. But that is a big piece, is really making sure the families are getting support in their native language. Some potential barriers as far as a referral goes is if there's a custody concern. So if either there's custody between two parents and child is back and forth between visitation, maybe they do a few days on, a few days off, or if the child is child welfare involved and that they're in a foster home and parents don't have as many visits with a child, we do ask that parents have at least visitation with the child at least 3 times per week, whether that is if they're in foster care or if they're in their biological parent's custody. Without the 3 days per week, the parent doesn't have the ability to practice the skills as often as they need to really build the success and feel confident in that. We've done a lot of work with child welfare in the past. Even if they have 1 typical visit per week, we work with them on can they have 10 minutes 2 other times per week, and are there ways that we can work this out so that they're able to see the child and practice the skills, even if it's just for 5 or 10 minutes as they're going. We also work to avoid starting PCIT with temporary caregivers. So if it's a brand new foster placement or they're just there temporarily, we really work to build that relationship and attachment with the caregiver, and we wouldn't want to do that if we knew that it was going to be a short-term, like 3 to 4 weeks type situation, because we want to build that long-term relationship. Same if there's a new significant other in the parents' lives, we really work to make sure that this is going to be a person that hopefully for the longer term is able to be involved, and that we're building a relationship and attachment that is going to be able to last. We have had some parents ask about siblings. We don't do PCIT with the older sibling being the coach, because we don't want to put another sibling into the caregiver role if they're not an adult. So they would have to be an adult to be able to participate in treatment with the sibling. Physical impairment with the caregiver is not something that would rule them out of PCIT, but we do, and I'll go into this a little bit more, our second phase of treatment is focused on timeout, and the parent has to be able to get the child to a timeout setting. And if there's a significant physical impairment, that may be difficult. And so we just work to explore what would that look like, how can we support them, what are their needs, to make sure that everyone's able to do that safely as they go. If there's active substance use, we don't recommend PCIT right off the bat. We want parents to be in their own recovery and be able to, again, think clearly and be able to use the skills. That being said, we have worked with PCIT in a residential treatment program for substance abuse. And even if the families are a couple weeks clean, we're able to work with them. We just want to make sure they're not actively using at the time that we're doing the treatment. And the last thing is, if there is any concerns of a parent or caregiver being suspected or charged, or there's any concerns around sexual perpetration, we would not be doing PCIT with them. Really, we focus on, again, building that attachment, the relationship, the security, and trust with a child, and we wouldn't want to be working with anyone that is potentially a risk to the child and teaching them those skills. So that would be another potential barrier. Just to go over a little bit, so in more detail, these are some of the potential reasons that children are referred to us for PCIT. So it can be any variety. Sometimes they have tantruming behavior, disruptive behaviors, difficulty listening, following directions, aggressive behaviors, hard time managing in preschool or school settings, poor social skills. For caregivers, it may be that parents are feeling like their kid just won't listen to them. Often parents and caregivers struggle if their kid has been expelled or suspended from school or daycare, or if they're on the verge of getting expelled, because there's not a lot of resources at that point. So parents seek out services, or even just conflict between parents. Sometimes parents that are separated or divorced parent very differently, and we work to really try to get them on a similar page in how they respond. It's never going to be the exact same or perfect, but we work to provide some consistency between parents. So this is just kind of a slide that talks a little bit about some of the spectrum of behaviors we deal with. So some kids come in with more kind of mild non-compliance, some whining, low self-esteem, and we've worked with kids all the way up to the more physically aggressive, destructive behaviors, and everything in between. This is a list of typical diagnoses that I had mentioned before. Really, there's not a diagnosis that would prevent them from getting PCIT. It's really focused on what is the need or the behavior that we're working to focus on, and how can we use the skills with that. So I just want to pause. I'm going to go into next, just providing a little bit of an overview of what PCIT is, what that looks like, how the phases are set up, and some of the things that we would work on with parents, just to give you a general overview, but I wanted to see if there were any questions at this point.
If you have a question, again, you can unmute and ask your question, or you can pop it into the chat.
Okay, I'll keep going, but feel free to jump in at any time. So from start to finish, a child comes into services and we do an intake or an assessment to determine what are the needs, what some of the background, what services have been provided already, assessing for a diagnosis, and really gathering information on what is the focus of treatment. From there, we move pretty directly into PCIT services. So the first phase of treatment is called CDI, or child-directed interaction. And we're going to go over the skills next of what that means, but the first phase is really focused on helping the child be more calm, more organized, more focused, really looking for that positive interaction, the warmth in the relationship, and there's a set of skills that we go through with parents that we look on them being able to master before we move on to the second phase of treatment. Typically, I would say the first phase of treatment takes anywhere between 6 to 10 weeks, but again, it's parent dependent on how they're doing as far as the skills, practicing, and how the child's responding, so that it's all determined based on the skills and how they're doing. The second phase of treatment that I'll go through in more detail is PDI, or parent-directed interaction. And in that phase, we really focus on helping the child learn to listen and follow directions the first time that the parent tells them to do something. We do use a timeout sequence as far as helping the parents if the child isn't listening. And we work with parents in the moment on how to deal with it, how to work through the timeout, how to work through challenges that come up, behaviors that come up, and really getting the parents to the point of being confident that when they give their child a direction, they know that their child will listen and follow through that, so they can be confident when they take them anywhere as they go. After the parents have gone through CDI and PDI, then we look at graduation. And for graduation, we really look for a mastery of the skills. We look for that ECB score, the screening form, to be within clinically normal range. And one of the biggest things is that parents feel confident in their abilities and that they have the skills to manage any behaviors that come up. We're not looking for perfection in the parent or the child. We recognize that kids within this age, they're going to test limits. They're going to have things that they push buttons and they test their parents. And we really want parents to feel like they know how to respond in any situation that comes up and that they feel confident. And we'll work with them as long as they feel like they need that support. Some of our families are able to graduate treatment, but then they still want to check in every couple weeks or once a month for a couple months, just to have that added support and someone to rely on if they need extra help. Outside of the typical therapy session, which are your normal 50 minutes a week or the once a week family therapy, we do ask parents to practice the skills 5 minutes a day. We call that special time. And really, it's important for parents to be able to practice the skills, use the skills, and for the kids to get kind of their daily dose of treatment. So we work with parents on learning some of the play therapy skills that a therapist would be using with a child, but the parent's able to use them every day as they're interacting with the child and able to see that change more quickly. And this is where parents need to have access to their child at least 3 days a week, even if that at minimum is 5 minutes at a time that they can practice these skills with them. And then, like I mentioned, we use the ECB to track parents' report on progress with child's behaviors. So in CDI, I'm just going to kind of briefly summarize some of the skills we go over with parents. We work with them on learning what we call the pride skills. So we work with them on praising the child and specifically praising the behavior they want to see improve. So we help parents really catch their kids doing well, give them praise when they are listening, sitting still, following directions, sharing their toys. Any of those pro-social skills that we want to see, we help parents really start to build those up and help the child get a lot of attention around those behaviors. We work with them on reflecting what the child's saying and really being present when they're interacting with their child and listening and responding to them and reflecting back what they say so that the child is getting that constant attention. And I talk with parents around, it's really hard sometimes to be mindful in the moment when you're interacting with your child because there's so much going on throughout the day. There's stressors, there's work and dinner and laundry that needs to be done. And so we really work with them to have 5 minutes so they can just sit down and really focus their attention on their child. We work with them on imitation, so playing with them, practicing some of these social skills, joining in with them, teaching them how to interact with other kids, describing the positive behavior, and then enjoying that time. So we really want this to be a positive quality interactive time between parents and children to help strengthen that relationship. And then we work with parents on what we call the don't skills and what we don't want them to do during PCIT. We do really emphasize that PCIT is a specialized play therapy technique. So outside of PCIT, parents are still going to be using some of these things, but when they're focused on those 5 minutes a day or in therapy, or really as much as they're able throughout the day, we work with them on reducing their questions, reducing commands that are unnecessary, and then any negative talk or criticism. We really work on building the positive attention kids are getting and kind of ignoring those negative behaviors that can be ignored so that the child learns they get attention for the positive behaviors rather than the big reaction for some of those negative behaviors. After parents have mastered those skills, we move to the PDI phase of treatment, in where we give commands and we work with kids on listening the first time to the commands. And we spend a lot of time going over with parents how to give what we call an effective command. So working with them on having commands be direct versus indirect. So being really clear with what we want the child to do rather than phrasing it as a question or a choice. Being very specific and really positively stated on what do we want the child to do versus what we want the child to stop doing. So I see this a lot where parents will say things like stop running, but the child will skip or hop or jump or crawl, which is not necessarily what they want. And so we work with parents on being really specific, saying, please walk or please hold my hand while we're walking, so that the child is very clear what the ask is and what they're expected to do. We also work with, again, making commands developmentally appropriate. So parents sometimes have an expectation of, you know, get dressed, get your shoes on, be ready to go, and the child may still be learning to put their jacket on or learning to tie their shoes. And so helping a parent break those down to be something that the child has already mastered so that they're able to be successful, rather than setting them up for failure by giving commands that the child isn't able to do. We work on commands being given one at a time and in a neutral tone of voice so that it doesn't get to the point where the parent is frustrated or upset or using their middle name or raising their voice. We really want the parents to be able to give a direction to a child and that they're able to listen. And then we work with parents really on only giving commands when necessary. So we definitely don't want to turn this into the child needs to listen to everything all the time, anytime a parent says anything. And we want the parents to be more mindful of when are things that we want to really have the child listen to versus when can we give some choices or when can they have some control in other ways and help them be independent in their own person. So we work on kind of balancing how to give those commands and then how to follow through. And then more about the PDI phase. So we do work through how to use a timeout if needed if the child doesn't listen, and how a parent is able to then take a step back from trying to control and manage everything that the child's doing. Often when kids are having a difficult time listening, they tend to get more emotionally escalated, and then the parents get escalated. And we work with parents on how can they help stay calm in the situation. The child takes a time out, gets a break, has their own space to calm down so that they can come back to being successful and following through with the command. One thing that is, I would say, unique too about PCIT is even after a child's done a timeout, the expectation is they come back to the original command. They don't use a timeout to get out of doing something that they didn't want to do, and that they learn that by listening the first time, they have more time to play or do other things, and that by not listening, they go to timeout and still have to come back to the original command. A lot of work here is done with parents and just staying calm, staying quiet, not engaging, and working on some of the power struggles that happen. Often I see kids bribe or negotiate and try to convince their parents to give in, and we work with parents to be really clear, consistent, and predictable and following through with what they say, so that the child's able to feel confident. They know exactly what to do, exactly what's expected, and that they feel more confident that their parent can follow through and handle situations that come up. And then, like I had mentioned, so timeout is a result of a child not following directions. It's not meant as a punishment. It's more meant as a break for them for not listening. We focus on them being calm and quiet at the end of the timeout so that they're able to think more clearly, they're not escalated, and they can return back to the original command. And this is just a little graph, for example, that was created by Dr. Cheryl McNeil. She is a global trainer in PCIT, meaning she trains people nationwide and internationally, and she and her team helped create this. And it kind of just gives a nice overview of what PCIT looks like. And CDI is really the foundation of treatment. We work on the warmth and the relationship and the positive social skills. And then we use commands as needed. And we roll it out in a really gradual step. So first we focus on what we call play-based commands. We move to real life and cleanup commands, commands throughout the day, house rules, and public behavior. And we work with parents on really starting with the easy stuff and building up on successes so that both the child is successful in following directions and the parent feels successful in being able to set limits. I worked with parents practicing this in public where I call in on their phone and we're talking as they go, you know, on the bus or they go to a library, and this was all pre-COVID. But helping them practice some of these things outside of their home environment so that they have support as they're going and that they feel confident using these skills. So in the office, the way this was set up is we have the caregiver and the child in one room, and then we have a one-way or a two-way mirror that separates where the child and the parent are playing and then where the therapist is. We use earbuds or headsets, and there's a variety of different ways this is done to be able to talk to the parent and give them feedback in the moment, that then the message is coming from the parent to the child as opposed to a child listening because the therapist is present. We really want to teach the child to respond to the parent, both positive and limit setting, rather than just change the behavior because the therapist is there. We have specific toys or recommendations on toys that we use that we have in the office or that we talk with parents about what are some toys that they can use during PCIT. And then we have a ton of data sheets and we track everything to really help us stay mindful of what are the behaviors that the parent is still struggling with the child and how can we tailor treatment to what their needs are. During COVID, we've been able to do PCIT in a very similar way. Instead of having a two-way mirror, we have the computer screen or the tablet or the phone that serves as our kind of two-way mirror. We use the phone or the telehealth platform to be able to talk with parents. And like I had mentioned at the beginning, we have seen a lot of improvements and a lot of changes by being able to provide PCIT in the home. Often when it was in the office, kids know it's a different setting. Often they're on their best behaviors or on better behaviors in the office where it's a more controlled environment. But in the home, there's siblings, there's pets, there's toys, there's all sorts of other things happening. And so being able to help parents work through and brainstorm how to address some of the concerns in the home, how to set things up a little bit different in the home if needed, and just kind of planning for the environment has been really helpful. We've also noticed a much lower dropout rate and more attendance and consistent attendance. And I think a big part of that is picking your child up, taking them to the office, doing the drive, the wait in the office, the therapy session, going back home, really is a lot of work and often is a lot of stress that puts on a parent if they're already concerned about their child's behavior and taking them out in public. Some kids really struggle in the car and they have tantrums in the car. And so having this be able to take place in the home environment where they don't have to go anywhere, they can be in kind of more their natural setting has been really successful for parents to be able to attend more regularly and stick with the skills as well. A lot of the parents I've worked with have come in feeling really embarrassed or ashamed because of their child's behaviors and often the looks that they get from other parents or adults when they're out in public. So it's nice to be able to provide that support to them where they don't have to worry, and it's really about how we can help them feel more confident as they go. And then after treatment, so once families are able to graduate from treatment, PCIT has done a ton of research to show that up to, I think the research has been done up to 5 or 6 years following graduation, the child's behaviors are still within what is clinically normal for their age range. That there's not an increase in behaviors, they aren't needing ongoing treatment after the fact, and that really the parents and the child continue to report positive interaction and relationship. Often they don't need other treatment outside of PCIT. They're able to graduate from treatment and successfully end therapy services, at least for the time being, or they may be referred for more specific treatment like TFCBT. We do also offer what we call booster sessions for parents. If in the upcoming months after they've completed treatment, they feel like they still need support or they've slid back on some of the skills or a new challenge comes up, that we can work with them on providing support as well. So that's the information I have, and I just wanted to check in about questions that you guys have, or if there's any specific cases or anything I can help with.
Again, you can unmute or you can pop your question into the chat if you have one. Okay.
Okay. So I'll leave it at this, and then Patricia, you're welcome to send out the PowerPoint I sent you as well. This is my information. I'm happy to talk through any questions, if there's any cases you have, if you have questions about would a family be appropriate, or anything that we can do, I'm happy to help as well. At our Virginia office, we do have 3 different therapists that are trained in PCIT, one of which is Spanish speaking and can do PCIT in Spanish as well. But we do have 3 therapists, and my goal is to continue to hire and train new staff that we can really expand the opportunity for services as we go.
Great, thank you very much for that. I just want to give everybody an update. So Jessa currently is not a CSA funded provider, but we are working on that. So just keep an eye out on the provider directory in the next couple of weeks. And I think, I don't want to speak out of turn, but I think there might be a change in that direction. So just FYI. Again, thank you, Andrea. I really appreciate your time and your information. I think it was really helpful. And again, we will be making this recording available on the website. So if folks want to revisit the conversation, or if you want to forward the link to your colleagues who were not able to make it today, I think they will find it really helpful. So thank you again. And we wish everybody a good day, a good week. Bye. Thanks.